Welcome, everyone. Thank you for joining us to this Lunch and Learn brought to you by the Utah Area Health Education Centers. And I would like to first of all say thank you for joining us in the middle of this hot summer day. And why, with all the things that we have to do, especially if we have children at home. So, thank you again so much for joining us. And I would like to just jump into introducing our guest speaker, and it's Dr. Haley Haffey. We are so lucky to have her talk to us about something that I think we will find very useful, especially considering the things that are going on in the world right now, in general for life, but also for our practice of health and healthcare. So, a little bit about Haley is that she's a lecturer in English from Wilson College, and she teaches courses in healthcare and medical humanities. And she has spent the last 4 years as project manager of the Internal Medicine Pediatrics Rural Pathway at the University of Utah. And she's also affiliated with the University Center for Health Ethics, Arts, and Humanities. And she is certified in the practice of narrative medicine. She has projects that concentrate on this very essential, I would say, essential practice. And she has projects that have to do with clinical practice, enhancing clinical practice, and healthcare education, and always with a special interest, huh, Haley, on rural and under-resourced health care. And so we need you. We are happy to have you. I'm just gonna give you the floor, and I you should be able to share and everything. Do
Perfect.
you like people on or off when you're
Oh, it's
speaking?
it's totally up to them. I tend to it's up to them. So
All right,
um,
there you
make
go.
please feel
Welcome.
comfortable. All right. Well, I'm so happy to be here and to see everyone. Let me just adjust my screen a little bit. Are you able to see my slides?
Yes.
Okay, okay, excellent. So I am here to talk about narrative medicine and why we need tools for working with stories in healthcare. We use so many tools in healthcare and so many devices and have so many interventions. And as a person who teaches literature, and Dr. Lopez gave a little background about who I am and what I do, as a person who teaches literature, I constantly deal with stories, and I'm really attracted to the ideas of the clinicians who recognize how much clinicians deal with stories. And it occurs to me that often people think about active listening or listening and listening to stories and assume that just listening is enough, even if you're, responsive and going through the active listening processes and repeating back. There are still mechanisms to thicken the narrative and to get a deeper sense of what someone's talking about so that it's not just repetition. And even in practices like motivational interviewing, you can sort of get lost on the methods as opposed to the form and not think about the content. And so narrative medicine is very much about thinking about the relationship between form and content. And so we're going to think about why we need tools for uh, listening and narrative in medicine. And then we're going to think about why and how narrative medicine can be the answer. And then we're going to practice a little bit. And so you might recognize that today we have some challenges with reading and attention in our culture. And there are a lot of recent articles and studies that are dealing with this. But it's not just that those in healthcare are distracted. It's that everyone along the line, all the way down to children learning to read. And there is some residual effects due to the pandemic, but also we have these intervening issues with devices that we're constantly presented with. So there's really kind of an attack in some ways culturally on our attention, and that doesn't help for situations in which we really need to deal with stories. And so studies show that uh, patients are interrupted about 12 seconds into their opening statements, and that they're interrupted about 70% of the time. So for most patients to experience being interrupted in a clinical interview after about 12 seconds is sort of startling. Um, I want you to think for just a second about the last time you were in a clinical encounter and think about when you might have experienced being interrupted, what that was like. or if you're a clinician, if you notice interrupting someone. We know that listening to stories transforms clinical interactions, and one place that we've really found this to be important is in SUD and OUD care. One study showed that exposing providers to patients who have experienced struggle and recovery with opioid use has been associated with altered provider perspectives on using MAT, improvements in clinical practice, and ultimately alleviating the stigma barriers and bias that affected patients face. And further, combining interventions that are contact-based and educational to expose clinicians to patient stories is the most effective way to change attitudes. So if clinicians can have their attitudes changed by being exposed to stories, it would make sense that we also want to have an apparatus for these stories. We're going to think a little bit today about narrative medicine, but I want to clarify and give some background that there are a lot of different ways we talk about the arts within healthcare. And they're not, narrative medicine can sort of be seen as something that's very broad, but there's actually a really specific meaning that I'm going to get to. So to give a little bit of background, we can have literature and literary studies, which is literature is a broad field that can include themes of illness and health in an academic context. So you might see someone in the English department writing a paper on depictions of malaria in Victorian writing. How the health humanities is a little different still. In the health humanities, you have an interdisciplinary field combining multiple areas in arts and sciences to explore the relationships between the arts and health and to consider also issues related to health through the arts. So using arts as a lens, both of those work, and there are also many other permutations of this. Narrative medicine is still a slightly different practice. It's a practice and a discipline in medicine, so it's not just a field of study. There's actually a workshop working element, and it combines philosophy, literature, and other cultural studies aiming to use narrative and arts-based interpretive methods to improve healthcare. So you notice there's really a goal within narrative medicine and there's a practice. So this is where slightly different again than literature, which is much less, if at all, clinical, health humanities, which can be clinical, and then the difference, of course, with narrative medicine that really aims to focus on clinical work. So here we're going to think about how narrative medicine can provide tools for working with stories. We're going to think about the definition of narrative medicine, the signature method, the movements, and the principles. So if you could think for a second, when was the last time you read a poem? Does anybody have a poem that they read recently? Dr. Lopez?
Dr. Rodriguez raised his hand,
Okay,
so
yeah.
let's let him talk.
Yeah, Dr. Rodriguez.
So recently I read this poem, Ithaca, by I don't remember who wrote it, but it was about the journey to the mythical island of Ithaca and what you encounter along the way and how you are the captain of your own journey. And then, of course, one of my favorite poems is Puerto Rican Obituary by what is it, Pedro Pietri? Is that his name?
Mhm.
And that poem talks about the 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 line that sticks to me always is Olga dies dreaming because it's really what the plight of Puerto Ricans was when they first moved to New York. And my parents, my father and my grandparents were in that second wave of people who moved. And so it's a very, very descriptive piece of what my family lived.
Okay, that's a perfect example of why stories matter in some ways because you're seeing yourself in this story and you're connecting to it. I also love the example of Ithaca because Ithaca is going to be related to the story of the Odyssey, right? And Odysseus's journey. So we're going all the way back to the Homeric ballads, right? And so that it also shows us the connection of different people over time. So those are great examples. Dr. Lopez, something you've read recently. I saw you had your hand up.
Well, I was reading something that a friend of mine wrote, and she's working on publishing a book, so it's unpublished. And but I do believe, Jose, that you wrote a book of poems, and I don't know if that's right or wrong, or
That's
yeah.
correct.
So Jose is um, an avid writer, I think, in general. So yeah, So no, but poetry in general, when we talk about what's going on today, I feel like people are going to that, right?
Right. Yeah, yeah. And tell me if you can, has anybody else read a poem recently? And if not a poem, how about any other type of a story or a book? Even a flash story. And if you haven't, that's okay. A parable. The shortest stories can really work with the faculties we're going to talk about today. So when you read, and surely I'm sure everyone has read a poem at some point, how do you approach a poem? How's a poem different than maybe a novel? What are the things you could expect?
So this may be totally wrong, which is, my specialty. I like to learn from my mistakes. But anyway, I look for kind of like I read it in my head, kind of like out loud, and I look for like a rhythm, almost like a beat, almost like like a song. To me, songs are poems.
Right. Okay, perfect. And many poems do have rhythm and meter. And the more, if you're going to read a sonnet, it's going to be much more formal. If you're going to read a modernist poem, it might focus more on images or constructing an image. I'm sure many people have read Red Wheelbarrow by William Carlos Williams, and you have the shape of the wheelbarrow actually coming through the poem. What I want you to think about is how, when you think about approaching a poem, the way you think about that is going to be maybe different than how you approach a novel. It's going to be different than how you approach other things that you're going to read. And you've built up some practice, some memory in your head about what the skills will be. Just like when you approach different people, you are going to know different types of faculties that are relied on. But the skills that we use to get to different types of stories can then be applied to how we relate to other people. And so in narrative medicine, we often think about how a patient is like a poem. I've heard Rita Sharon say this many times. She suggests that, and this is not to objectify the patient, but to say that there's a readerly curiosity we can have when we approach a poem or when we approach a book. And if we have that same type of curiosity, it asks us to ask more questions. It asks us to be curious, and it also invites us to listen. You might realize too that when you read a poem, you can't just project your meaning onto the poem fully, or you won't get the meaning of the poem. You have to be willing to listen and to take it in. And so there are definitely dynamics. There's a relational dynamic that we can learn from in the process of reading. Has anybody ever thought about how your patient can be like a poem, since we have poets in the audience, medical poets? Sanitani Dasgupta, who is yes, Dr. Rodriguez.
So, Sayantani and I went to residency together.
Yes, you just told me this. This is amazing. Go ahead.
So I was going to mention what I just told you before, Dr. Haffey, and that is that, I had a patient who came in to see me the other day, and she told me that she wrote a short novella on Kindle. So I downloaded it and read it, and I was amazed. It was funny. It was called Oliver Katz Hates Cats. So but that opened up an exchange with this patient that I'd never had before. And she is actually the only person that's purchased my poetry book. And she sent me a poem that was autobiographical about her. And it just blew my mind. She's in her 70s and she's talking about growing up essentially unsupervised and how foreign that is to me and how it makes it so difficult for her when I ask her to take her meds. And so it was a great way to find understanding. I just
Amazing.
I sent
Yeah.
that I sent that to family medicine just 10 minutes ago.
Yeah, no, that's amazing. And that's exactly the type of thinking more interpretively about a patient. There might be something that you don't discover directly by looking at them in that clinical setting. And what can deeper reflection and deeper engagement with their story, and literally you're engaging with her story, and not even a metaphor there, right? You're going and reading her book on Kindle. But there's ways in which we can work with this as a metaphor for those whose patients don't write. Santonia Dasgupta, in her article Narrative Humility, writes that about the connection between the literary and medical process. She says this entering into the suffering of another is akin to the work of the novelist, who must get to know his characters like new acquaintances, and allow the story's plot to unfold before him. It's like the act of the careful reader who enters into the metaphor of the poem while allowing the metaphor of the poem to enter him, granting yet undiscovered meaning to his life's events. So there's this real kind of and I think that Dr. Rodriguez's example was perfect. This what we'd call a dialectical process where you're bumping up against another story and then taking that in a bit and then being slightly changed by that and then listening and hearing more and then slightly changing your perspective. And so this is really kind of give and take communication process that has to have some element of what Dr. Dasgupta was talking about here, which is narrative humility, some sense that there's something to be discovered. And that's one way too that reading the patient like a poem is so powerful, to realize that there's something to be discovered, something that you don't yet know before you read. And one problem that there is in medicine is this assumption, especially since there's so many algorithms and protocols that are worked with, that every patient fits into them and therefore we have quick answers. And just like your example, Dr. Rodriguez, of a social context that was more historical and someone having an unsupervised childhood and not liking the monitoring that might go through, keeping up with someone's medications, there's this, struggle of all these things we don't know. And we don't even know what we could ask in many ways. So Rita Sharon, who really founded narrative medicine, has a quote that I always share and really like. It's about her experience in her residency. And she's an internal medicine doctor who got a PhD in literature at Columbia while she was working on her residency. And in her residency, she says that, quote, "I came to understand that what my patients paid me to do was to listen expertly and attentively to extraordinarily complicated narratives told in words, gestures, silences, tracings, images, and laboratory test results and changes in the body, and to cohere all these stories into something that made provisional sense, enough sense, that is, on which to act."
Hmm.
So any thoughts or responses?
I mean, I think it's I'm savoring the words and the word choices, right? The words, gestures, silences.
Every
That's
time I share this
that's a big
quote,
one.
yes, go ahead, go ahead.
No, no, I said that's a big one, the silences. Like when people are just silent and you just take that for consent or just like, I got it, and they just keep going, going, going.
Absolutely. Someone's posture, right? There's so many things. And then, and we'll talk in a second about the kind of these other elements of story, but you can think about how there are intersectional elements of story. What's connecting to the silence? What's weighing on the posture, right? So what can we learn from thinking about these as a story, not just items? And stories that have doorways that we are not sure what is behind yet or might not even recognize. Back to another quote to think about how this relates to the larger picture is that we can imagine that individual stories are so important when you think of the social context that they may reveal. So in another really important article, Sayantani Dasgupta talks about this idea called abolition medicine, where she says that narrative medicine teaches us that stories matter, particularly at moments of crisis, trauma, and upheaval. Language affects the way that policies, actions, and attitudes are shaped toward justice or injustice. Who tells a story, who benefits from that story, whose voice is heard and whose silence, who is framed as heroic and who villainous. We can imagine how that could fit into many different situations when we're navigating social determinants of health, when we're navigating a person's situation within a larger family context, and even within work and other contexts. So thinking about how individual stories can give way to a network or a system of stories is also a really important part of narrative medicine. And so the most basic fundamental definition that I really like that is Rita Sharon's kind of go-to definition is narrative medicine is clinical practice fortified by knowledge of what to do with stories. And so it's that idea of it's not just listening to a story, but it's having a sense of what to do with it. And that means that we not need to know how to interpret it to be able to act. So that takes us back to that silences and images and tracings and gestures. There has to be a method to interpret these things, to put them together, to have enough of a sense of how they cohere so we know what to do. And that takes us also to ethics, right? To be able to put it together in a way that gives us an ethical response. So within narrative medicine, oops, sorry, we have practices and principles, and the signature method is close reading. It's connected to 3 movements, attention, representation, and affiliation, and 6 principles, which is a guide of supporting ethics, academic rigor, and relationality in the use of narrative in healthcare. So we will take a look at those. So the signature method is close reading, and we get that from formal literary theory. That's something that we might do, especially in the realm of just literary studies. In literature, we ask, what is the text bringing to you? And in medicine, we ask, what is the patient bringing to you? So it's that question of what is there that you don't know about? What is there in your patient's history that could tell you that they don't like being closely monitored in terms of their day-to-day activity, and they could be labeled as non-compliant, but really they just grew up with a different atmosphere around them. So it's important to ask ourselves, how do we interrupt our own reading and listening, thinking that we already know the answer? And you can probably imagine too, how this is something that would be so familiar for any relationship. And so narrative medicine in many ways can expand and help other elements in our lives, because it's really about working with the stories that are in front of us. So whether you are working with your partner's story or your child's story, thinking about things in terms of stories and not just facts or things that have happened in a sequence to cause you to respond is really enriching. And it also can help delay the time between stimulus and response and add reflection. And it gives you something high quality to be contemplating in that space between stimulus and response. And so in close reading, it's something very basic that I'm sure everyone here has heard within the context of something like a literature class that maybe you took in high school or college. Paying attention to things like time, voice, space, setting, mood, word choice, motion. When we translate these into sensory details, we want to always be thinking in narrative medicine, what do you know and how do you know it? And how does that thing that you think you know really tell you what you know? So when's the last time has anyone, could anyone remember thinking about contemplating setting when you've talked to a person, when they were energized about a story? Or when's the last time you thought about specifically word choice or motion, right? These things aren't necessarily terms that we pop into our day-to-day conversations, but if you start doing that and have just a little handful of terms that you remember, a handful of literary tools, it enriches things. So if you might think, for example, how is time working? If you're talking to someone in your family who potentially, is a child, right? How does time work with children? How do they experience time? Does it change? Okay, Dr. Rodriguez, do you have a thought?
They have no clue on time.
Okay.
It's like it could be months from now or it could be minutes from now, and they have no way of telling the difference.
Right, right. So when you hear a story, right, from a child, connecting that to time might be totally different than an adult's orientation to time. But you might learn something about the importance of something they're telling you if you see them condense time, if you see them expand time, right? When do they pay attention to it? When is something the longest thing that's ever, transpired, the longest wait in the world, right? As opposed to a short wait, as opposed to other situations, you might be dealing with a patient who has a memory condition. Would working with time be different in that sense? That would change the story. If someone's experiencing extreme grief, could their experience of time related to their health change, right? We all have memory omissions. How about motion? When does it matter to think about motion? If you think about someone who's gesticulating wildly, you might get a sense of agitation, right? But maybe you didn't think about how there's movement, how movement is happening. If you need a story about the mechanism of a fall, if you're in a clinical setting where that's the case, you might want to think about motion. You might want to specifically pay attention to cues that you get related to motion. You can then, from the small list of of terms, be able to take a few that you know within a certain type of appointment. You want to really bring these skills to. And so this is part of what Rita Sharon talks about, having a signature style. She points out that we learn something, and I have a quote about this later, we learn something about ourselves by paying attention to the signature elements that we listen to. And that gives us a sense of our biases, good or bad, right? Maybe most of us listen for mood. How do we know we're getting a certain mood? What are we seeing, hearing? How does it feel? What are the other elements? So can we see posture related to mood? Can we see tone of voice? Thinking this way expands the way we absorb these elements of story around us and gives us a chance to listen for things we might not traditionally listen for. If we don't typically listen for voice, we might want to listen for voice in the future. Any questions on those thoughts, questions?
I was thinking about two of the things that you mentioned. I mean, especially time
Right.
and I guess motion. No. Yeah, motion. And how that's also filtered through the lens of culture.
Right. Yes, every one
Mm,
of these. Well, how about space too, right? How close the clinician is to the patient, how much space the patient needs. Does that
mhm.
then have some intervening weight in terms of their mood, right? So what are really the kind of the physics of these elements? What is the physics of these elements? What are the equations that create the equation that's giving us the result that we're seeing? Right. So when we put these things together, they're going to have a certain outcome, and we can change the outcome with attention. And so that's where attention really falls into play here. But it is about reading, and you're learning to read these things that aren't necessarily words on the page, but that reading words on the page can teach us how to do. And so beyond thinking about close reading, narrative medicine wants us to think about how we relate to each other. And so we have these three movements: attention, representation, and affiliation, and they all kind of work in a cycle and bring us to a better connection. So it's the idea that paying attention to these elements that we've just talked about in close reading and somehow representing them back to the patient, giving them a token. This is kind of like active listening. Like I heard you say this, right? Letting them know, creates a bond, creates trust. And so it's really, these things create a cycle of trust. So the idea is that you need to continue that and continue kind of the generous cycle of paying attention and wanting to have that connection to build trust. And it's attention that comes with not just wanting an outcome, but wanting a different sense of relationality. And so we can think of attention, curiosity, reading the patient or the person with engagement, but also professional objectivity. Providing evidence could be representation, some type of token that they know you've listened, and then affiliation, connection through shared storytelling. And I think that Dr. Rodriguez, you gave us a great example of that through sharing the story that you read on Kindle from your patient, right? That's definitely a sense of affiliation. You're connecting. You represented what you read from the patient back to them and created a bond around that. So, thoughts or questions on that cycle? You can imagine how even even in a situation where you're dealing with, say, a patient with OUD, right, who's nervous about coming in, to validate that they're nervous and they might not know exactly what they need next. But that you've heard them say something, and to say it back to them could create trust that just even in that moment, right? It doesn't have to be going to read the patient's story on a Kindle, which is amazing, but just even validating in a small moment that somebody is human and matters is something that we really see coming through when we do a lot of workshops. I've worked with Brenda Luther in College of Nursing. We've done a lot of workshops with people in recovery doing simulations, and they've really talked a lot about how when someone gives an indication that they're a valuable person, some token back to them, that it totally transforms the relationship and the environment of the interview. So that really also takes us to the principle. So you can see that this is not, narrative medicine is really not just combining literature or writing with medicine, but really is a bit more in depth. And so we have these 6 principles that are also really meant to guide this work. 1 is action towards social justice. 2 is disciplinary rigor. 3 is inclusivity. 4 is tolerance of ambiguity. 5 is participatory and non-hierarchical methods. And 6 is relational and intersubjective processes. So action towards social justice means that narrative medicine has an aim towards a socially just and ethical healthcare. Disciplinary rigor means that narrative medicine is invested in doing the intense work that makes the process of narrative medicine sensical on deeper theoretical levels. For example, the whole attention, affiliation, and representation model that I just explained is deeply rooted in the philosophy of phenomenology. And so there's a lot of work around ethics and narrative medicine that relate to deeper philosophical movements. Inclusivity is thinking about how it matters to have a variety of people on a team, a variety of people of different backgrounds connected in this work, and that relates to the action towards social justice. Tolerance of ambiguity goes back to, just like you were saying, Dr. Lopez, the silences, right? We might not know how to read a silence, and we may need to tolerate that. We may need to rest with a question mark, and that is very difficult in our current healthcare system. It's also something that's difficult in terms of people having conflict over ethics, right? And what social justice is. And so there's a certain need for pausing on a much broader level. Participatory and non-hierarchical methods. That means that you might have in a narrative medicine workshop like I do. That means I would invite people who are MAs and MD PhDs to be in the same group. Doesn't matter if you're an attending or a resident or a assistant nurse. Everyone, when you interpret a poem, is going to have a different reading. And I've taught a million literature classes and a million poetry readings, and people all have insights that are valuable. And it's the same with working with patients. And then relational and intersubjective processes. This is really recognizing that this is not just about getting to an outcome. This is much about creating a better sense of relationality on a systemic level. So it's really about thinking about systemic justice. And when we talk about systemic barriers and systemic problems, this is an answer to that. So applying narrative medicine, we can use narrative medicine to learn about patient context. How does a patient's food insecurity or unstable housing relate to their perspective, tone of voice, or their health over time? Does a clinician consider or ask about settings, work and employment safety in the assessment? How do place-related environmental factors, pollution, weather, et cetera, change the story? You can think of many different ways, inroads, paths toward thinking about social determinants of health when you start thinking about things like tone, things like how could we imagine the setting if it's in a polluted environment, right? So you can start asking what those other details might be. Just having a framework gives you a pathway to get to details that can tell us about systemic factors. I like this quote to bring things back to literature a little bit. There's a book called Portrait of the Artist as a Young Man. It's one of my favorite books I like to teach. It's about a young man who wants to be a priest, but realizes his true calling is to be an artist and a writer. And he sees himself as a priest of the eternal imagination, transmuting the daily bread of experience into the radiant body of ever-living life. And I think that this capacity for transformation that we see within narrative medicine really is taking these common daily things and experience and turning them into something powerful, and that gives us a good relationality that can change the way we understand each other in healthcare and the way we value each other in society and healthcare. And so I love this metaphor. And I want us to practice a little bit. So I guess any other questions, thoughts or questions? So I want to see how you can kind of scale up these. And we use the arts as well, broadly speaking. So let's take a look at this painting. And I want us to do what we would call a close reading, but also slow looking exercise. So just take this in for a couple seconds. Notice how it makes you feel. Try to think what is giving you those cues. Try to think of a close reading. When we look at art, we all have different things that might draw our attention, even in the same painting. So could I get anyone to tell me what you see here?
Hi, this is Nikki. I'm feeling the light and the shadows.
Okay,
I can feel the wind coming off of what looks like the ocean or a body of water.
okay, good.
Just
Tell me
a
why it looks like
lovely,
this is going to seem obvious, but tell me why you think there's a body of water there.
um, the blue, which usually represents water.
Good, good,
Um,
excellent.
so it's a warm afternoon, spring, summer, fall, and just a very calm scene.
Okay, good, calm. Tell me what says calm to you. Anything else? What says calm?
It looks warm. It looks slightly breezy, and it looks like something I could take a nap in.
Okay, 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 good. Anybody else? Yes, Dr. Rodriguez.
So when I first looked at the image, I thought it was like relaxing. Like this is the kind of thing that you think about for a summer afternoon nap. And maybe that says a lot about where my head is right now. But the other thing that I was struck by is that I couldn't tell if this was a photograph or a painting.
Good. Yeah, excellent. Okay, can you tell me some elements of why you couldn't tell?
Because it looks so real. I mean, it looks like a regular photograph, but when I look at the shadows on the floor, they don't exactly match up. So I'm a little concerned. I'm a little confused, and maybe that it's not a photograph.
It's definitely a painting.
Yeah.
Okay, so I will tell you that. Yes. And Nikki, you said it seemed warm, right? Very obvious, but tell me, why does it seem warm?
Sunlight.
Windows open.
Good.
Sunset.
Yes. That's the type of detail, right? It definitely seems warm. Dr. Rodriguez also said you want to take a nap there, right? We know that if the window's open, it's probably warm enough to take a nap, right? And we get the sun on the curtains, a slight breeze, but it doesn't look like a hurricane, right? The sky's pretty clear in the background. But those are the type of issues saying, oh, the sky's clear. I don't think I see any clouds. If they do, there's really, I don't know the type of clouds those are, but they're so faint. Um, and there's a gentleness in the way the curtain's hanging, right? How would you describe that? I know that Dr. Rodriguez, you said the shadows don't match up, but you got the sense that there are the shadows there, right, on the wall.
Mm-hmm.
To me, it looks like outside is very hot, but inside it's nice and um, it's cooler and
Good.
it's
And how do
and
you get
maybe that's the state of my health or something, but I
no,
don't I don't
I think
tolerate heat very much.
but see, and
But
that's a great, right? That could be a bias playing in, but also when I look at that, Dr. Lopez, I can see that the room is all in a shadow and there's only, bits of sun on the wall. So actually there's
mhm,
quite a bit. So it seems like it's in shade, right? Whereas
mhm,
inside, I don't get a bit of shade. I get full sun. So I think that you're absolutely picking up that dichotomy. But when we put it in the terms of the room is full shadow and outside is full sun and the wall is the barrier, right? And
mhm.
the curtain is mediating that. It sounds a little different. And it also gives us evidence, right? And so that's like the representation going back. You absolutely intuit and get that it's cool and nice inside. People tend to be, I think that that's kind of a common reading from this group, and that it seems very warm outside. But when we start putting it together, we're going to all notice little tiny different elements, right? This gets infinitely more complicated when you're dealing with a patient or a patient that presents with an ethical dilemma. That's why building muscle memory, and if you can do this in a group, an interprofessional group, a group with your team, ideally in the same working group together to work on these skills, to read a poem together, regardless of what your work environment, if you're academic, if you're clinical, to work on interpretive skills together, arts-based interpretive skills, gives you the foundation to go read real world experiences and real world examples of what you might need to interpret. Any other thoughts? Okay, I have one more. This is a poem, and this is how I also kind of like to scale up a bit. So, we won't have time, but you could easily, after an image, a poem, go to a clinical case, right? And then see how your interpretive lens kind of shifts. But could I get someone to read this poem for us out loud?
I can do it with a Spanish
Oh,
accent,
yeah, that
but
would be
I was
great.
hoping
Yeah.
that some student would volunteer.
I can do it.
Go ahead, Nikki. Go ahead.
Okay. The lesson. I keep on dying again. Veins collapse, opening like small fists of sleeping children. Memory of old tombs, rotting flesh and worms. Do not convince me against the challenge. The years and cold defeat live deep in lines along my face. They dull my eyes, yet I keep on dying because I love to live.
So I don't typically give the name of the author. I'll say this is a famous author that I'm sure everyone's read. But part of the point of narrative medicine is to not have a competition to see who knows an author, but to see just what we're seeing on the page. So what is happening in this poem, or just what are things that you notice? Because sometimes we build a narrative just by noticing things.
It seems that this person is at the end of their life. They're older,
Okay,
um, with the dull of the eyes and the lines in the face,
good.
and with dying on their mind, usually is not by a younger person.
Good, good. And there's a discussion of memory too, right? It gives you a sense that maybe they're attentive to that. Good, good, Kathy. Also, so nice to see you.
You as well.
She's a
Anybody?
fan.
Sorry, go ahead.
I said she's a fan
Oh, I'm a
of
fan of
yours.
you. Yes.
To
Anybody else?
me, it speaks about like maybe they're being asked to do something or to hold some value above what they think, and they don't wanna.
Good. Tell me where that's coming from.
Um, Not convince me against the challenge.
Good, good.
Yeah.
So Kathy, you're saying an older person, Dr. Lopez, someone who can't be convinced against something else. What else? Dr. Rodriguez, any thoughts?
I was struck by the piece about the beginning with dying and ending with dying, and that dying really is what living is about.
Good, good. And where does that come from? How do you get that? What are the things that are like bringing that to you from the poem?
Well, because when it says I keep on dying again, it seems like dying is a process and it's not something that happens once, right? And at the end, where the author brings it back together to I keep on dying because I love to live. It's that juxtaposition that gave me to that idea.
Good. Excellent. Excellent. And okay, so thinking about that, right? And thinking about it seems like then in that sense that maybe the thing they can't be convinced against is having to relinquish and just let them die or let themselves die and not die again, right? Because it's what they want to do is continue to engage in the process. I keep on dying again, veins collapse, opening like the small fists of sleeping children. Memory of old tombs, rotting flesh and worms do not convince me against the challenge. I keep on dying. I'm not convinced against the challenge. The years and cold defeat live deep in the lines along my face. They dull my eyes. So something's getting worn out, the years and cold defeat. Yet I keep on dying because I love to live. So the only way to live is to make it through some type of deathly encounter, right? So that's kind of the turn or the pivot. And
Constantly facing death.
right, constantly facing death. Does this sound like a patient you could imagine?
Oh, yeah.
In what way? How could this be like a patient?
Well, because it is, again, I keep going back. It says, I keep on dying because I love to live. And it sounds like that's a contradiction.